Welcome to Be Well with MS podcast series, where I and expert guests discuss science and science-based tools for everyday life to preserve brain health and quality of life living with MS. I'm Dr. Agnes Strokjana, neurologist, researcher, innovator at Torbay and South Devon NHS Foundation Trust in the UK. So, today's guest is Professor Smear. He's a professor of neurology at the Blizzard Institute, Queen's Mary, University of London, and consultant neurologist at the Royal London Hospital Bars Health NHS Trust, where he's a research lead for neurology and clinical lead of the day case unit and Bars MS. I had an honor to first meet Klaus in Turkey at MS Information Day, organized by MS Society in 2018, and since we kept the contact. He's someone who puts his energy and spends hours to improve patients with MS lives. And he's also one of the kindest and honest person in the MS world and supports and advocates healthcare professional women in science and clinical work. So Klaus is a very well-known national and international speaker on various different topics in MS. And if you have not followed him on Twitter, I highly recommend to do it now. He has nearly 4,000 followers already, so really highly recommend. So please welcome to the show, Professor Klaus Smear. How are you, Klaus?
Thank you so much. You're too kind in your introduction, Agne. Yes, I'm well, thank you. How are you?
I'm good. Multitasking, doing everything, being on call and doing various different activities. So I'm very honored to have you on the show and have a really sort of a brief discussion about a very, very important topic, which is brain health living with MS. And our topic that we are going to cover and discuss in a very sort of smooth and friendly way is early diagnosis and time to treatment to preserve brain health for people with MS, and whether we think that radiologically isolated syndrome is just an asymptomatic multiple sclerosis. So, Klaus, I just want to talk maybe about how many people do you think has got a delayed diagnosis of MS, and is it something that has been improving over the last 30 years or not? How does that feel for you?
Yes, I mean, I don't have the figures right in front of me, but I think the Shift MS recently ran a survey about this, and it was around about 20-25% who were diagnosed within around about 3 months of their first manifestation. But there was a significant number of patients, about the same quantity, that where it took 2 years or even beyond that. Now, I believe this is already clearly an improvement from what we've seen. We all know that sometimes people turn up have had symptoms for years and years. Very often those who may not have had so many physical symptoms that led them to seek help, but were very early on affected by depression or cognitive change, etc., that wasn't picked up early enough to lead to a referral to neurology and to a diagnosis of MS.
Yeah, I totally agree. And we see such a variability of patients coming later in having already advanced disease. And some of them were diagnosed many years ago, but they never had any adherence to the services. They just lurking in the background, never sought any advice or medical input. They were told that they got MS and they have to live. But actually, with the advanced therapies these days, it's really no-brainer not to have engagement with the medical services, with the MS teams in the country and in general. It's really, really important to know that.
Yes, I mean, getting them early is really key because putting even early treatment aside for a moment, once the diagnosis is made, the access to services generally improves because you've got the MS nursing team usually involved, and that allows self-referral, direct access, not having to go through the loop of GPs or A&Es, and that improves things significantly for many. So
Yeah.
yes, early and rapid diagnosis, accurate diagnosis is really important.
Yeah, yeah. So we can't strike how important it is, and getting all that help, even if it is just symptom management, it really improves the quality of life living with MS. You don't need to suffer with pains and migraines and headaches and bladder and bowel issues. There is a lot of help, but it's just raising the awareness that you really need to seek some attention and go and talk to the GP doctor who could always refer you to the MS services around the country, even if you live somewhere else in other countries. So it's essential to get that access, because you get symptom management, B, you got very advanced therapies in MS that if you are only eligible for these therapies, it's only a benefit to control your disease activity. Now, Klaus, so what does the brain health means to you? What is it? What do you think it is for you as a person?
Yes. I mean, for me personally, I think, I mean, we can obviously start with the definition of the World Health Organization, but I mean, as in, complete physical, mental, social well-being. But I think it is fair to say that a great deal of what we consider brain health has to do with our overall health and how we feel in ourselves. So anything that has to do with that makes you feel well is, I think, something that it has the potential enhance your brain health. Now, for some, this might sound odd because they enjoy drinking a lot of alcohol or smoke, whatever. So this is not quite true, of course. But so a healthy lifestyle overall, I think, is generally good for your brain health as well.
Yeah.
Now, I think people advise certain allocation of time for themselves. I often find that quite difficult, particularly with children. I think very little alcohol. That's I mean, for me personally, that applies. No smoking or other, toxins. Looking after your weight, and when I remember, I take my vitamin D.
I saw you're a great runner, Klaus. You do some running.
Yeah, I do at times. I mean, I had a great time running with a group, but the time in the morning, and in fact also the time in the evening, is often um, covered by other activities. It's an adjustment to life all and family life as well.
We say that time is something that we create. There's always no time, and
Mm,
we're always very busy, and that's sort of almost like becoming a norm to be busy. I guess
yes.
instead of saying, oh, when you meet a colleague in the corridor, we're sort of rushing and sort of say hello to each other quickly, and everyone's like, oh, I'm busy, perhaps we should change it from saying busy. We should say like, yeah, we're working hard
Uh,
working.
yes. Or yes. Or I'm relaxed. I'm relaxing whilst
Yeah.
working now.
When we are
Yeah.
relaxed, we should say that, because something that as a human beings we're sharing, we
Mm,
are somehow can inspire, by our feelings, other people,
yeah.
how they feel. Like there
Yes.
is a continuous communication and transition of your
Yeah.
moods and emotions and feelings onto another. So perhaps we should, be
Mm,
mindful, and when we feel relaxed, we just say we are feeling okay. Actually, I'm chilled and
well,
relaxed.
yes. Well, I think that being busy is has a very positive connotation in the professional context,
Yeah.
and being relaxed or even doing nothing
Mm.
is considered then you're kind of lazy, right?
Yeah.
Uh,
Almost like a
and
negative.
and it's self-perpetuating. But of course, I mean, we our activities, our lives are busy because of the jobs we do, and but yeah, segmenting it and making time, as you say, is also important. You can tell me the tricks about, I mean, how you do it. I'm probably not quite so successful.
I think I live on the piece of land that is very isolated, so it's not many things to
Do you
do,
think
to
that
be honest.
helps? Yes.
We spend a less time commuting, so it's a bit more time for ourselves. So Klaus, moving on to more scientific background
Mm,
and talking about, the effort, the energy, that we require to be fit ourselves to provide the best care we can to the patients. And I think our main focus these days are, early diagnosis and time to MS disease modifying therapies. The shorter the period of time, the more people are exposed with disease modifying therapies, the better the outcome overall. And sometimes it's really challenging to choose and to find the right medicine. Do you believe that it's important, and how important, what the data suggests, that the earlier we diagnose people, that the earlier we start with medicine, the better it is?
Yeah, I think there's obviously various trajectories from which you can look at sort of early treatment. There's, for example, this very nice Italian study that describes how you end up at an EDSS of 6, or the percentage of patients that end up in an EDSS of 6 related to age and in certain periods of time. So before the treatment period started, even 80% were in EDSS 6 at 6 years of age, and the proportion of that gradually seems to come down as we develop further in terms of disease-modifying treatments. I think the data is quite, albeit always circumstantial, it is convincing enough. We need to remember that this type of data obviously also incorporate other elements. For example, and that is an element that I've always highlighted in the context of the risk-sharing scheme of the interferons and Copaxone, that in the context of that, a big boost was given in terms of supply of MS nurses. And so once you have more staff and personnel involved, then people will have their urinary tract infections or generally sort of bladder function better managed. They get to their physio appointments, various elements that just improve. But I think disease-modifying treatment, looking over time, has clearly also improved outcomes. So this is the first, I think, perspective, as it were, a bit of a bird's eye perspective. When we look at large data collections, I think for me, one paper that I often quote is by Hay and colleagues from the MS space that looked at early treatment with either highly effective versus platform therapies, suggesting that highly effective treatment, perhaps not entirely surprisingly, but still clearly seems to show benefit in relation to disability accrual. And times have changed in that in the past, highly effective treatment was always associated with high risk, but that is no longer true, I think. Over the last 5-7 years, since the latest crop of compounds become available, we can't say that anymore. And therefore, I think as we generate more and more data, also of longer term safety, it becomes increasingly clear that we can very much focus on efficacy and really squeeze the best out of these drugs that are still incomplete, but still, I think, have brought a step change in the management of people with the disease. And therefore, I think that it's convincing enough to start early and also get in with something that we believe is most likely very effective.
Yeah. So I guess when we start early medicine, our target is to switch off the active inflammation. And as a consequence, if we have a good control of activity and active lesions, for example, that's a phase that maybe this condition is going to just terminate in that phase and will never maybe go to the neurodegenerative process, although we know that a certain degree of neurodegeneration starts at very, very early stage of the condition. Some
Yes.
radiologically isolated syndromes already have an element of the brain atrophy, and you know, and it is really challenging to sort of cover with disease modifying therapies the both pathogenesis, you know, of the condition. And if we knew the pathophysiology a bit better of this condition, perhaps we would have more direct therapies that would tackle certain cells for individual and more personalized way would be implemented to care for people with MS. It's something that is coming, perhaps, isn't it? You know,
yes, I mean, I think it's personalization is obviously a kind of a whole separate issue, I think, but we are approaching that. So some drugs we're already dose, for example, adjusting the dose, okay, to body weight, sometimes also to other elements like lymphocyte count. So I think there is a sort of certain degree of personalization already ongoing. But when you're rather sort of looking at who is at sort of higher risk or lower risk of early deterioration, we're obviously all aware of a number of factors that on a group level predict poor outcome, right? I mean, high number of spinal cord lesions, motor system involvement, brainstem or cerebellar lesions, poor recovery after a relapse, the time between the first few relapses, male sex, higher age. I think these are all kind of indicators that we know from natural history studies. But in the individual, I mean, first of all, in the individual, things can still be different. Okay, there's still people who have all this whole bag full of poor predictors and are doing reasonably well, and there's quite the opposite. Now, I would say if you have these negative predictive factors, it's quite easy what to do, right? You go in and with highly effective therapy. The question always arises: those with mild MS or mild symptoms, mild signs, a few lesions, what to do there? And I think in the context of what I said just before, in terms of safety of highly effective therapy, we need to put that to the individual concerned, right? Because I think we often tend to think too much along the lines of clinical studies, in that because something is highly effective, and particularly in those with significant disease activity and pathological load. We also tend to, in the individual, then to focus on those who have, in short, bad disease. But if you're looking at, I mean, the individual concerned, I mean, and they are, able to run a marathon, for them, only being able to run half a marathon next year or in a couple of years' time, that may be a significant change in their quality of life. Okay, so a drop in that, just as much as somebody who is already, I don't know, has difficulty walking to walk even less. So I think we need to very much include really the individual concerned in those decisions, and even what we consider as relatively mild may be significant for somebody who has the disease, and therefore we need to be open about, well, what's out there, what can you do, and have that open conversation, and don't make too much judgment from our own perspective. Just essentially, inform the individual concerned about what's out there, what the opportunities are.
Yes. Yeah, absolutely. And it's not always about, personalized treatment, but it's about personalized measurements for that individual. What is the baseline and how that changes over the time. And if it is a half of the marathon running, in the last 12 months, that's a significant change, so that's it. We have to go with that switch, and it's a highlighter that of course we should do something more aggressive rather than sort of choosing the first line or second line, you would go for a high efficacy perhaps.
Mm.
And I guess this is where we're going to attack MS. This is a clinical trial that you're chief investigator. Tell us more. What was the driver? What was the how did you decide to
Yeah.
set up this clinical trial?
Yes.
What the evidence is behind that?
Yeah. I mean, it essentially what it does is um, it extrapolates what we know so far from early highly active treatment. Okay, so here's a drug we're using for many years, natalizumab, and we know this is highly effective, and it is one of this of several that were used in studies to compare highly versus, versus platform therapies. But even in those studies, it's clear that there was quite a gap between first symptom and start of treatment, about a year. Now, if we want to essentially flatline the disease at the level of function that people essentially were before they developed their first symptom, um, we, um, we felt it valuable to test whether an even earlier intervention is useful, and so what we are planning to do, and in fact I just received today the confirmation from the of sponsorship for the study, so we can now actually open sites for the trial.
Congratulations. Wow, that's
is
really good. What a
it is.
timing.
Yes, yeah, perfect. And is to recruit people within 14 days of their first symptom
Mm.
onto highly effective treatment versus placebo for the first 3 months. And then they will all roll over onto the active arm. So it's a 6 month trial. It is at 3 centers in London, and people can receive steroids as well.
Mhm.
And we measure. We have two primary outcomes in this study. Are we able to recruit within 14 days? This is
Mhm.
going to be, the
That's a
biggest
challenge.
challenge.
Yeah.
Because it's a change of practice, right? I mean, so
Yes,
far
very much so.
we're thinking, okay, we see somebody in A&E, and then they come
Mhm.
back to clinic, and it may take a few weeks or months even
Mhm.
until they get onto treatment. And this is exactly what we're trying to address. That this delay may lead to early damage that we may not be able to
Mm.
so easily to
Yes,
recoup.
yes, Klaus. I think this trial almost requires working with primary care, GPs,
Mm,
ED doctors, some sort of a
that's right.
sharing wide, everyone needs to be. And if you're just about, you don't know whether you got MS and you feel you got MS and you've just seen
Yes.
a neurologist, I think always mention that Professor Schmierer is running the Attack MS clinical trial, and
Yeah.
ask
Mm,
yourself to refer to the centers that runs this clinical trial. I think it's a nice opportunity. You not necessarily, at this time moment would match the criteria to go on the Tysabri treatment
mm,
because it's classed as a second line disease modifying therapy. It's a very highly efficacious and potent drug, so
mm.
you may not be eligible, but by a clinical trial, you could get access to this powerful medicine.
That's right. I mean, this will be the first option, or really the only option, I think, at the moment for anyone with clinically isolated syndrome to
Yeah.
get onto a highly effective treatment. There obviously has been in the past attempts doing this.
Yeah.
For example, there's been the Oracle study of cladribine tablets, which was very successful, but the drug is obviously not licensed for this indication now. And I think one benefit of Tysabri is what is usually considered the downside, which is that it is relatively rapidly in as well as out of the system. And with a B cell depleting drug or an immune reconstitution treatment, you obviously have a long term effect at a point where many are uncertain about the diagnosis, or there's some trepidation because you are not 100% sure. And with something like Tysabri, which is, as I said, in and out the system within 6 to 8 weeks, you are even in the unlikely scenario that you are wrong, then it doesn't cause any harm. And when you look at thrombolysis rates, so about 20% of patients who are thrombolized don't have a stroke. So I think we need to obviously take that into account here, but it is still, we believe, worth doing that, testing it certainly. So I was talking about the primary outcome, which was are we able to recruit? The second co-primary is magnetization transfer ratio in lesions, and that'll be measured after 3 months to essentially see whether such highly effective treatment at the very beginning is able to facilitate remyelination, because MTR is quite a good correlate of that in an MR of the brain. So yes, it's attackms@qmul.ac.uk. Just get in touch if you have somebody. And it doesn't have to be in London. We've got 3 sites there, but we also have governance approval that we can recruit from outside of those 3 centres. That's the Royal London, Chelsea and Westminster, and St George's Hospital. People obviously need to travel, but remember, these are people with their first manifestation, so they are generally well, except for the new symptoms they have developed. So you can also travel outside of the M25.
And last question around this clinical trial. So what happens after 6 months, Klaus? Is it something that you would continue under the NHS, the Tisabri?
That's right, yes. And we've negotiated that with NHS England, that people can still receive Tisabri after the 6 months, so they can carry on the NHS.
Wonderful.
Alternatively, alternative medications are also possible. Then that's all per clinician and the discussion between the clinician and the participant. Then
I guess if the PML risk is high, so you could negotiate and then discuss with your neurologist and perhaps transfer on an alternative.
Absolutely. Yes, yeah. I mean, you're free to do then what is kind of clinically indicated. It is just reassuring that you can continue on the treatment as well, if that is what your and your clinician's choice is.
Wonderful. That's a great opportunity, and I think if you feel like you're a good candidate and you're eligible for this clinical trial, feel free to refer yourself, and Professor Schmierer will take on board yourself. Right. Okay. Let's talk about it's a hot topic at ECTRIMS 2022. It became as a highlight, but homeopathic stem cell transplantation is not as effective as other disease modifying therapies. What do you believe is that accurate? Do you think it's a reflection?
Well, I think I think the ECTRIMS highlight was perhaps a bit of a sobering experience to an extent, right? In that there was a comparison between HSCT and natalizumab, and there was essentially no difference between the two. I think the real answer will come with the 2 clinical trials, hopefully, that are currently underway in the US, the BEAT-MS study, and here in the UK, the STAR-MS trial. I think this is how you need to do this. Otherwise, you will sort of always rely on uncontrolled data, and people will sort of make up their minds and opinions. I personally think that HSCT is unlikely to become a mainstream therapy. We will not unlikely be able to remove the cancer risk completely, depending on the drugs used. I think for women, it will remain a difficult choice to make. Egg collection and all the ramifications of that. So I think personally that it will be a very select population we will treat. It will become more routine, but I still believe it's going to be a small fraction, a small proportion of the overall patient population. But I think, we'll have to wait and see for the actual trial data to make the call. I know people are very opinionated, and when you go on Twitter or online and discussions are emerging now, it's very black and white often, and I think we need the data.
Yeah. But some promising results that our highly active disease-modifying therapy are as effective as hepatic stem cell transplantation.
Yeah, you can turn it exactly. You can flip it around, right, and say, well, this is as effective as what
Yes.
you think is kind of the best therapy, right? Yeah.
Exactly.
Yes. Yeah.
Right. Okay. So let's talk about a bit of a classification of MS in general. I am a strong believer that MS is one disease and very much depends, how advanced this disease is, when we come into people's journey and we try to intervene with medicine and everything else. Do you believe that radiologically isolated syndrome is a type of MS, but it doesn't produce symptoms as yet? It's asymptomatic type of MS. What is your opinion on that?
Well, I think it's quite clear, right? I mean that from what you said earlier, even when you have somebody with radiologically isolated syndrome who turns out to have MS, and there's no then it's always been MS. Okay, there's not a transition. This is just the same disease, but you weren't able to detect it at that stage, or you weren't able to confirm it because the diagnostic criteria are what they are. And so they have the same degree of brain atrophy and other features otherwise in terms of the biology of the disease. It just hasn't manifested in a way that we can easily detect or pick up. So clearly those that turn out to be MS always had MS. The issue remains there is how do you balance essentially the, say, 50-50 risk, right? That people don't turn out to have MS, and if you sort of treat them with something that has potential for harm, alongside the entire medicalization for somebody who may not actually have the disease. Okay, so I think there's a whole package to consider over and above the biology of the disease that matters here. What we're essentially doing to people's lives to give them this 50-50 chance. But otherwise, yes, clearly RIS, clinically isolated syndrome, they are part of the MS spectrum. If we then confirm it is MS, CIS, RIS has always been MS.
It's a matter of the documentation, bureaucracy, investigation, summarizing, timing, waiting to get all these results. I think it's...
Yes. And I think also, I mean, we're obviously always dependent on our in-exclusion criteria in those studies. And by necessity, simply as we further advance and understand the disease and its manifestations better, if we are better at cognitive testing, and if we examine people more with double inversion recovery at the very beginning, we all do high field scanning, we will more and more essentially filter out those who indeed have MS and those who don't, right?
Yeah.
So I think you can think in the future, right? If we have more widely distributed 7 Tesla magnets, for example, I mean, we put people in there because clearly you get a 30% increase in lesions you detect.
Yes, there is a sensitivity issue, like how good we are at detecting the condition at early stages. Am I right that from ECTRIMS highlights, there was a study that they used fingolimod for radiologically isolated syndrome, and they found that this effective drug to minimize...
It was actually a dimethyl so Tecfidera. So yes, okay. That's right. So Darren Akuda presented that. Yes, and I mean, again, as you would expect, right? You reduce the likelihood of converting, as in confirming the diagnosis according to the criteria you've agreed upon earlier on. You delay that. And quite substantially, significantly, even though it's kind of only DMF, you could say, but it turned out very potent in that context. So I think more evidence to I think come up with scenarios where you start treatment even in the setting where you're uncertain that ever, as it were, clinical symptoms emerge, right? And I think that will no doubt be the discussion over the next months and years.
Yeah.
How do you best define those with this high risk?
Yeah.
And again, the significance of adverse risk of the intervention will play an important role in how this is being balanced. But clearly, if somebody who's got a sibling with MS, okay, who's got very low vitamin D level, whose HLA profile puts them in the high risk category, I think these are factors that can then be considered. And if you then find lesions, even if somebody is completely asymptomatic, then there may be a case for treatment.
Wonderful. You may just stay in this RAS zone for many, many years, if you get the right access to the drugs, so
that's right.
That's very promising. I think it's
absolutely, and in a funny way, right? It'll make us more difficult to prove actually what the point, right? Because if you sort of delay, then it becomes it may become even difficult to say, well, would this have actually developed into MS or not, right?
Yeah.
So you're intervening, and I think it's going to be a fascinating field, because here we are talking about early and very highly active intervention, and we're pushing that envelope, that border yet further back to before the actual clinical manifestation.
From your just observations, do you believe that to preserve the brain health, even it's difficult to prove that, but your ATTACK-MS clinical trial is going to be a groundbreaking trial,
Well, I think hopefully it'll be a step on the way. Okay. I think I imagine, right, have this sometimes that we essentially have a couple of doses of natalizumab or whatever other compound with similar properties in the A&E, or at least accessible in our pharmacies quite rapidly, and we treat really very early on, straight away, because with a compound like this, you can obviously give it and then think again. I think what often it flips around a little bit, the approach that we generally probably have now. We explain the disease, which you will still do, right? But I think we're thinking about many aspects of the condition with the anticipation of development of disability and difficulty. So we give advice on that anticipated deficit. Here it is more about, well, essentially, trust me, I'm a doctor. It's a bit like thrombolysis, right? Within the first few hours.
Yes.
And then we can talk, right, further about what to do next.
Yes.
I think this is how I see it, kind of changing practice.
Yeah.
Hopefully.
Yeah.
But I still think this is not going to be the end, because, as we just said, radiologically isolated syndrome is waiting next. Yeah.
Look, Klaus, I think thank you for your innovative way thinking towards improving access to the treatments and nourishing and preserving the brain health with all the access that people will have, when they sign for the clinical trial, and perhaps that will become our routine, and we really will manage MS like a stroke. In the front line, we will have maybe more neurologists working actively and looking after people with MS in ED setting. It's not even if it's a long-term condition, but it become very acute condition in the presence of active relapses and new changes that paralyzes people in a very abrupt, strokey type like presentation, which requires a lot of energy, a lot of effort, thinking, planning about the safety, getting access quickly to the drugs. Is a lot of logistics. So we need to make sure that we have nurses and managers on board working, helping us to provide that care that we would like as a clinicians to give access to all these all the treatments that are available, and they are really powerful if they are being done in time. So, Klaus, what do you have as a quote in your life, that you think often and you're led what is your inspiration these days? What do you think is stimulating for you to live healthy, to do various different trials, to look after people with MS and run clinics, travel around the world, give all these fancy speeches? What is it?
I think that's probably in itself motivation enough, right? I think it's wonderful to try and make a difference, right? And not only for people locally, but hopefully, as you do through research, or at least you should intend in clinical research always to make a difference for people wherever they live with the condition. I think this is really what drives me, particularly in the professional sense. I think, yeah. Otherwise, I mean, there's some more general sort of ideas, I think that play a role in life, but when it comes to profession and neurology, or specifically MS, I think this is what it is. This is what's always been very much sort of the undercurrent of what I've been doing. Not that I sort of was born with this, but it clearly sort of evolved to that.
Wonderful. So, Klaus, final thing is that to make these podcasts more interesting and engaging, would you ask a question to another Be Well with MS podcast guest on the brain health? I'm not going to tell who's next after you being interviewed, but just anything that you think would be relevant for these type of interviews that are more focused on the brain health.
Yes, and it is really based on an experience I made during ECTRIMS. There was a fringe meeting which was led by Ananta Kiran from Tel Aviv about early sort of coaching intervention with patients after diagnosis. And I thought this was a great program, but it really sparked the question for me, and that's something I think for others on this podcast, perhaps, what people's best practice is in guiding patients early after diagnosis and encourage them to start DMT. So this is really what I would ask my colleagues.
Thank you. All right, so let's wrap up. So thank you very much. So as you understood from our very detailed discussion around the early start of the medicine to preserve the brain health, that it's really important factor. And if you got MS and you haven't seen your neurologist for a decade, this is your little first step that you need to do is contact us, and if you would like to be part of the Attack MS clinical trial, get in touch with Professor Smear. We'll give you details and we will attach the email, how to contact Klaus's team. And I hope you enjoyed, and I learned a lot of things. It's really, really a big honor for me to interview Professor Smear.
It was a great pleasure to talk to you.
Thank you, Klaus. So I hope everyone enjoyed, and I'll talk to everyone else later. So keep listening and following me. Thank you so much. Bye for now.